Welcome. I'm Dr. Alex, one of the organizers of the 2026 Central Texas Parkinson Symposium. This presentation is one of 9 talks in a series created to inform, support, and empower individuals and families living with Parkinson's disease. You can watch these sessions in any order. Follow what feels most helpful to you. Links to the other talks, along with additional resources and ways to connect, are available in the description below.
Good afternoon. Can you hear me? Yes. All right. And I appreciate everyone coming and come back after lunch. And if you decide to use Dr. Elkin's relaxation technique during my talk, I won't be offended. Okay. So my name is Rich Phenis. I'm a neuropsychologist at Baylor Scott White, and I've been there since 2011. And I did my fellowship there from 2011, 2013. And I don't know if I was ever hired. I just kept coming back and they ended up paying me. So don't tell them. I'm not sure they know. But I'm going to talk about Parkinson's disease and cognition today. So I'm going to talk about an overview of the brain, just to give you an idea of the different functions of the brain. As a neuropsychologist, we have different ways to assess brain behavior relationships. And it's really cool because the brain has some localized areas where they do specific things. So the top right picture, you can see that the brain's divided in half. You have the left and right hemisphere. And if you're right-handed like me, majority of you have your language abilities on the left side of your brain. 95% of y'all. If you're left-handed, it's still the majority's on the left side, but not quite as high, about 70%. And the visual skills are on the right side. And then it breaks down even more from that. So if you look at the picture below, you can see towards the bottom, there's the temporal lobe region. That's where memory, semantic knowledge, so knowledge of what things are, words are. And if you move back towards the back area, there. So this is a occipital lobe. It pulls in visual information from the eyes and processes at lower levels. You move up to parietal lobe. That's the area that processes sensory information. It tells us of our location as far as like our extremities are in regard to our environment. And then the front part of the brain's the last one to develop. It doesn't process new information. It's unique that it pulls information already processed from other areas. And it allows us to do more complex tasks like multitask, problem solve. Also personality, a lot of it's located there in our motivation. And then if you look at this section here, you can see the brainstem. I know Dr. Shagafe mentioned the midbrain right here, and that's where the substantia nigra is located. And as long as our brains are functioning how they should, it's pretty cool. We really don't think much about it. But when you start developing a disease, have an injury, and you start having trouble, and it starts breaking down, that's when we start paying a lot of attention. And with Parkinson's, one of the things that's most talked about, well known, is that loss of dopamine in the brain. And then the picture down here shows the midbrain cut with the substantia nigra. It's this area here. I think I might have an arrow there. And then on the next one, it shows the substantia nigra with Parkinson's. You can see you lose that dark pigmentation. That's the dopaminergic neurons that have died off, so dopamine's not being produced as much. And this is a process, of course. You lose about 60 to 70% of those dopaminergic neurons before they can actually see the symptoms to accurately diagnose Parkinson's. So it's been going on for years before that. I mean, that tells you how long the process it is that's occurring before they can diagnose it. It also tells you how well the brain does with compensating when there is loss to some extent. And then in addition to dopamine, there's also loss of other neurotransmitters, so like norepinephrine, and that's involved with alert, arousal. It's that fight or flight that's involved in fight or flight. Serotonin, it's involved with mood and sleep. And then acetylcholine, which is involved with heart rate, digestion. So all these neurotransmitters are reduced with Parkinson's disease, and these neurotransmitters in particular, along with dopamine, play a role in cognition. So they help with attention, memory. Serotonin helps with executive functions like decision making. And there's some studies also show there's some atrophy in the front part of the brain in some patients with Parkinson's. And there's a reduced blood flow in certain regions like the frontal, parietal, and basal ganglia. And all these changes together explains why you have the observable motor symptoms and why some people may experience cognitive decline, mood disorders, and apathy with Parkinson's disease. So what happens if you have Parkinson's and you have concerns that there might be changes in your cognition? You let your physician know, and they should do a workup. A lot of times they'll review your medications. They'll look for some of those medications that are well known that can impact your memory, your thinking overall. And you all can kind of keep a track of this. So if you get changed to a new medication and you notice that that's when you start having difficulty with remembering and focusing, bring it up to your physician, because that timeline helps out a lot. They might send you out for lab work also. So simple things like making sure your thyroid levels where it should be, vitamin B12, B1 folate are in the right levels, because if those are low, they can impact your memory and thinking. And then they'll send you out possibly to make sure you don't have a urinary tract infection. Sometimes this is hard to pick up, especially as Parkinson's progresses or if you have Lewy body, because with UTIs when we're older, you can see fluctuations in our thinking, confusion, even sometimes hallucinations. And then also think about, medical conditions, are they being managed well? So if you have diabetes, it's not managed well, that can impact your thinking. If you had surgery, underwent anesthesia recently, you can have a delirium related to that. Some people might have some confusion afterwards. So they'll check all those things out. And then they may even send you for imaging of the brain. Brain imaging doesn't necessarily say, yes, this looks like a mild cognitive impairment or dementia, but they can rule out other things. So they can make sure it's not a tumor or something else that might be causing some of the difficulties. And then they might also administer a cognitive screener. So they'll sit you down, they'll have you do like a page where they'll put numbers and letters in order, copy cubes and stuff like that. And then if they have work you up and everything seems pretty good, then they might tell you that this might be part of normal aging if it doesn't seem too extreme. If they're still concerned after that, they might send you for neuropsych testing. And then before that, though, there's some other things to consider. So if there's sleep problems, fatigue, those can impact attention and memory. Depression, anxiety, which is pretty common in Parkinson's disease. Those things, it's like almost like a static radio playing when you're really depressed or anxious. It pulls you away from what's right in front of you, so it's hard to focus. And then psychosis, of course. If you're attending to things internally that aren't there, it's going to be hard to really pay attention to other things that's going on. So if they're still concerned after they work through all that, then they might send you for a neuropsychological evaluation. And I know some of you have had this done. So if I misspeak, don't correct me for everyone. So most people, it's a long day, but they usually say it's not as bad as what they thought it was going to be. And it's usually 3 to 4 hours. And the reason that is, we have to do a pre-thorough interview to get a background, because we want to get an idea of where you probably were before there were concerns about cognitive changes, and also to see if there's many incidents along the way before you develop Parkinson's disease or even after that could account for some of the cognitive difficulties. So we might be able to say, like, you've had a head injury that's pretty severe in the past, that might be playing a role in this. It might even explain it, not necessarily the Parkinson's, and rule those conditions out. And then with testing, it's paper pencil type test mostly. You'll be one-on-one with someone, they'll walk you through everything. And they'll look at memory, attention, language, processing speed, executive functions, and other areas of your thinking. And we do a number of tests, because if you do just one and you have a low score, that could be just you're distracted for that one test. It might not actually represent your true abilities. So we want to do multiple tests that measure similar things to make sure we're getting accurate readout of how you're doing. So testing is about 2 hours. It depends though. Some people are slower than others, and some people will need more breaks, so it might take longer. And then at least with myself and a few of the other people I work with, we can get your results in the same day usually. And then with a neuropsych test, so it helps identify if there's a problem. So we'll say, yes, there is a cluster of cognitive deficits on testing. They all point to similar regions. This makes sense that there's probably a decline. And then what type of problem that might be. Is it definitely a cognitive disorder? Is this mild cognitive impairment or dementia that we're looking at? And then we'll talk about the suspected causes, like is this Parkinson's related, looks like, or is this something that might have been in the past that just with age is becoming more apparent now? And then we'll talk about treatment and considerations based on the diagnosis and the things that you need to look out for in the future to keep an eye on. And then other conditions, of course, to rule out. And I also do the evaluation for part of the workup for deep brain stimulation. And so it's similar, it's a full neuropsych evaluation. And what I'm mostly doing is ruling out whether there's dementia present, because that's a contraindicated for deep brain stimulation. So traditionally, how cognition was viewed with Parkinson's was most people didn't have any weaknesses, really, deficits. And then over a few years, they might develop some processing speed might slow down a little bit. They might develop some attention problems and some problems with more complex tasks. And then over several years, some of them might develop dementia. Well, we're finding out that cognitive deficits are a lot more common than what we thought with Parkinson's. So about a third of people who have Parkinson's will show cognitive deficits near the time that they're diagnosed. And then the occurrence of dementia with Parkinson's disease is pretty high. So there's a lot of difference between how deficits present. So you still have that traditional thought that some people will have slowed processing speed, difficulty with more complex tasks. But we're also finding out that some people may not show weaknesses in those areas, but it might be more visual spatial weaknesses, or it might be more memory that they're having early on, or even language abilities might be lower. So it's not just one homogeneous type of disorder. There's a lot of variety with it, a lot of differences between. And then these are some of the impairments that you often see with Parkinson's, or can be seen. So attention, working memory, processing speed, even language abilities. It's usually verbal fluency and naming deficits, some difficulties with visual spatial skills. Memory, it's more usually like recalling information right away or retrieving it on your own. People typically do well when they're given choices. And then executive functions, so like problem solving, multitasking. So when there is declines in cognition, what does that mean necessarily? Well, from my point of view, I would determine that you have the diagnosis of Parkinson's, of course, and see that it's been a gradual decline where it does seem like it could be another condition that may be causing it. And then you have deficits on neuropsychological testing that's severe enough and consistent enough to indicate there is a disorder likely there. So once that happens, what we're looking for, if this is a cognitive disorder, is this mild cognitive impairment or dementia? And the main difference between those two is with mild cognitive impairment, there's declines, but they're not as severe, and people are still able to function pretty well on their own. With dementia, they have cognitive declines, but they tend to be more severe, and it's impacting their ability to function independently. Now, with movement disorders, it makes this difficult to assess because movement disorders, oftentimes the motor changes will get in the way of functioning. So you have to have someone who can take that into account and ask you the follow-up questions like, you're having trouble managing your medications, but is it because of the tremor or is it because you're forgetting? And if they say it's because of the tremor, but they remember to remind their spouse to give them their medications, then that tells me it's not cognition, that we're not looking at dementia at that point because it's more the motor symptoms. There's some risk factors for developing cognitive decline with Parkinson's. So age for any disorder is a big risk factor for cognitive decline. And then the longer you've had Parkinson's disease is a risk factor. In the older age that you develop Parkinson's disease and the diagnosis, having cognitive dysfunction at baseline when you're first diagnosed, greater motor severity, that also usually means that you're further into the disease process, hallucinations, depression, and then if you have the lower body dominant type Parkinson's, where you don't really necessarily have the tremor, it's more lower body, they tend to have a higher risk for declines in their cognition. So having declines in cognition with Parkinson's is associated with a number of things. Of course, some difficulties with daily functions. Even if it's not dementia, a lot of times people who have declines, they'll have to come up with strategies to get around some of the difficulties. So they may have to set alarms more or use reminders more often than they had in the past. And that's okay, because if you're still able to do that, that tells us that this isn't dementia, because you're able to work around it. On ratings and questionnaires, they have a lower quality of life that they endorse. They tend to have poorer treatment outcomes, and then increases caregiver distress. And I couldn't find a good place to really put these other recommendations in, but with caregiver distress, there's support groups. You want to involve family and friends as much as you can. I often recommend that once you get to the point where you need some help, try and set up so at least one day a week a family member comes in and gives you a break, and then communicate with them what you need as you go on, whether you need it more, often, or less. And then also awareness of what services are available for you. And then the greater the cognitive deficits, there's increased mortality with Parkinson's. So what happens when there is a problem, when there are cognitive deficits? So what you want to do is you want to look at medications. So now Dr. Shagafe talked about some of the antipsychotic medications. So some of those that block dopamine you want to avoid. That they can make the motor symptoms worse. They can also make cognition worse. And then also some of the anticholinergic medications. I think he mentioned a couple that he will use every now and then to help sustain the life of dopamine, of carbidopa-levodopa, but some of those can impact your memory. So anticholinergic, what they essentially do is they reduce acetylcholine, which is a neurotransmitter in your brain that helps you focus and form memories. And so these medications will make that less available. So some of the common ones that I see is with incontinence. Oxybutynin's one. Most of the medications for incontinence, unfortunately, have anticholinergic properties. And some of these, unfortunately, might be necessary evils. It's just one of those things you have to weigh, like, the medication's doing more than it's worth the risk of having some decline in my thinking for what the benefit I get from it. And then Benadryl is a common one I hear about. And it has anticholinergic properties and can impact your thinking memory also, especially with daily use and as we get older, and increase the risk of cognitive decline. And then Tylenol and Advil, they have PMs, which have medications which have Benadryl in them also. And then you want to add those medications that may help. So cholesterol inhibitors, so they do the opposite of anticholinergic medications. They try to increase the amount of acetylcholine in the brain to help you focus and form memories. So Exelon's been approved for Parkinson's disease. So it's been shown to help with cognition and then improvements in daily tasks. And also it's been shown to have improvement in apathy with some patients. Namenda is another one that I've seen used with Parkinson's disease, and it showed some possible mild benefit with cognition. And unfortunately, as Parkinson's progresses, these medications don't sustain their benefit. And then another thing that you can do when you have cognitive decline is exercise. Even when you don't have a cognitive decline, exercise is good. And you see young people exercise quite a bit. The great thing is that when we get older, exercise is actually even more beneficial to us. And what they believe is the brain-derived neurotrophic factor, BDNF, it decreases as we get older. So that's the theory of why it's better as you get older to exercise than when you're younger, or even more important, because you can increase that within the brain. And BDNF does a number of things. It promotes new cell growth, it protects existing cells, and it helps with plasticity within the cell structures. There's been studies that have also indicated that there's increased concentrations of neurotransmitters within the brain with exercise, and that there's some that have shown that there's even measurable changes within brain structures. I know Pittsburgh did one several years ago looking at just walking, and that they showed people who are walking 40 minutes several times a week compared to a group who was just stretching, they showed increased size in their hippocampus. And that's the area that's associated with memories. So some of the benefits that you can get from exercise, so physical, improved muscle strength, gait, balance, bradykinesia improves, and fatigue. There's studies that have shown that tremor can improve also. They've also shown that there's improvement in cognition with executive function and expressive language. And emotionally, it's helpful. It can protect against depressive symptoms and reduce anxiety and stress. And then people rate quality of life better when they're exercising. They seem to have a slower decline. And it doesn't increase dopamine in the brain, but it seems to make the brain use it more efficiently. So there's a number of types of exercise that you can do that have been shown beneficial with Parkinson's disease, and this is just a list of some of them. And the bottom one is even video games where you're up and moving around. And then I get laughed at a lot when I recommend that, but I usually do when there's grandchildren. Like if they have a game that they're up moving around, you might join them. And then on top of exercise, looking at medications, is just stay active. So some of those things where you lose it or use it or lose it. And so you want to be engaged in anything that's non-passive. So you don't want to sit around, watch television too much, and be inactive. And so being active is associated with better cognitive outcomes. So you can play games, do puzzles, you can take a language class, go on a trip with family. There's lots of ways to stay active. You can audit a course at a university, pick up or rejoin a hobby, and then also staying socially active. So going to church, going to clubs, dancing, doing things that you enjoy, being around people and interacting. So there's a lot of things socially that's beneficial. So, I mean, emotionally it makes you feel better, but having a conversation with someone, there's a lot of cognitive flexibility that goes into that. Because you think about what you're going to say, what they say, and how you're going to respond while they're talking. So it's really great for the brain. And then, again, support groups are really helpful. So in addition to all those, if there are cognitive deficits, it's helpful to know where they're breaking down at, and then what strategies you can use to get around them. So mostly you want to get it out of your head and into a system. So that means use a planner, use your phone, or anything that you can to help out. So I've heard some alarms going off. So it seems like y'all are already doing some of this for your pills. So that's a great strategy. So using pill reminders, pill box, leaving your pill box out where you can see it and it's not hidden away can be helpful. You can set alarms on your phones. That can be helpful also for remembering things, especially those activities out of the ordinary. So you have to call someone next Tuesday or you have to go pick someone up next Thursday. You can just set a reminder in your phone to remind you to do it. And then consistency. So for those common tasks that you do day to day, you want to try to do them in the same order as much as possible. So it's just part of routine. So that way you don't have to really think about it. It's just what you do every day. And then you want the structure. So as much as possible, stay organized where everything has a place and you make sure you put it back just to make life as simple as possible. And the routine, like I said, just try to make your daily task as regular as possible. And then if you are having problems with executive functions, you can break down tasks and do them step by step. So try to do one step at a time. You might even make a list of the steps so you cross them out off as you go. Try to limit distractions as much as you can. Because when there's cognitive decline, it can be hard to get back on track. And if there are memory issues, testing would help show where they're breaking down at exactly, but if you don't have testing, you can test it out. So you can have them repeat back what they hear, what they repeat back, that's how much information you know they got in, and then you can ask them later what they remember, and what they recall will give you an idea of how much you're retaining. So sometimes it's just people have trouble getting the information in right away, but they'll hold on to what they get in. So if you want them to remember something, a family member, you can say, well, repeat back what you heard. Now, if they only say 3 things, they'll probably remember that, so that way you might have to keep repeating until they get more of the information. Or give cues, choices to see if that helps. Now, there is a caveat with this, that you want to do that as much as possible as long as the family member is okay with it. Now, if it makes them irritable or something like that, it's not worth it. And then I know Dr. Shagafe mentioned the fluctuations that you can see, especially as Parkinson's progresses. With medications where you have the periods where there's dyskinesias, there's a lot of medication system, then you kind of hit that sweet spot where you're doing pretty well, and then it kind of plummets to where you're experiencing those symptoms again. You want to try to identify those spots where cognition seems better, movement seems better, and when there's important decisions, talk about it then as much as possible. Then some other considerations where there's cognitive difficulties is looking at sleep. So improving sleep, if there's an issue, can improve your thinking. It improves attention, memory, and executive functions. There's a mood disorder like depression, anxiety. Treating it can help with cognition, or if it doesn't, it at least makes you feel better. And then enlisting PT, OT, and speech therapy also if needed. And then if you have Parkinson's or a loved one with Parkinson's, some things to look out for if you have concerns about cognition. Usually the things that get impacted first are the more complex tasks. So you think about the basic things like dressing, grooming. Now physically someone might need some help, but they remember doing, they do fairly well. It's things like managing finances, driving, and those type of activities that tend to decline first. So with medications, work together, set up a pill box if you can. Use alarms and set reminders and to keep the pill box out so you can see it easily. And so the family member can walk over and they can check it here and there. And that way they know that you're taking medications. If you miss doses, then that way they can also jump in and help out when needed without being too intrusive. And then with driving, this is a complicated one. So with Parkinson's disease, you can see slowed processing speed, some executive dysfunction, so trouble multitasking, some visual spatial difficulties, and then motor, from a motor perspective, you might slow down also, which can impact driving. So when you're uncertain, get it checked out. Like occupational therapy can do a driving evaluation. You want to ideally stop before it's too late. Okay. So stop early if you can. Designate a chauffeur for yourself. You've earned it. And then if you are driving and have a family member ride along with you, you want to do it every couple weeks or every month. You can make a routine out of it where you go get ice cream or something and have the person with Parkinson's drive and see how they're doing. And what you're looking for is, are they weaving, having trouble staying within the lines? Are they driving significantly slower than what they used to, or it's almost a hazard because people are honking to try to get around them? Are they hitting curbs, so getting lost or turned around? So those would be some signs that there might be an issue. And one of the things I hear most, it's good that people have awareness, but it's also a sign that there's probably a problem, is when people start reducing the amount they drive, the distance they drive, and the speed that they're driving. That would indicate there's some awareness and that processing speed is not quite what it used to be. And then with finances, so just keep, if a family member with Parkinson's managing finances, just keep an eye on it. You might have access to their bank account, so you can just check whether the bills are being paid monthly, set things up as auto pay if needed, and then maybe even have a cosigner going into account. And then awareness with Parkinson's, with anything that impacts the front part of the brain, can be reduced. I mean, you want to trust what family members say, but you also need to verify to be safe. So when you have Parkinson's disease, it's important to plan ahead. I mean, it's especially important once you start showing declines in cognition. And most people I know will have a will already done. But it's the steps that get before to that point where the will is enacted that is often lacking. And so make sure you have power of attorney, even the caregiver, have a power of attorney in place to be safe. And then talk to family about what you want to happen if this was, as this progresses, if cognition was to get worse, if you needed more help, what that would look like when you need them to step in, what you'd want your care to look like. It's a really difficult conversation to have. It seems like the earlier people tend to have it, it seems be a little bit easier, but it's to give a person with Parkinson's the most say in what happens in the long run. Because if you wait and you have a cognitive decline, it might be hard for you to communicate what you want exactly. And the hope is also that it will help family. They won't have to struggle as much to try to figure out what you would have wanted. So in family, keep an open line of communication with other family members. If you need help or people step in, let them know. But in the end, we only have today. So make today count. So I know experiencing loss of functions independence is really difficult. It's scary to consider the what ifs, and it can be overwhelming and anxiety provoking. So talk to family, have a plan in place. You can only control today. So today, move, socialize, love family, play, do what you can. Plan for the things that you cannot control, and then address the things that you can. It's like when we talked about medication, other things that you can address, exercising as much as you can. So, and you've all done a great job managing today. You should give yourself credit for this. And perspective matters.